Welcome back to the Deep Dive. Today, we are taking a massive swing at one of the most critical and, frankly, most complex fields in clinical care.
hmm
We're talking about conditions affecting the central nervous system, or CNS. So if you want to be well-informed on what happens when the body's superhighway system breaks down, this is your shortcut.
That's absolutely right. We are tackling the core concepts from a foundational medical surgical nursing text, really diving into Chapter 37.
Right.
Our goal here is to synthesize the complex pathophysiology,
Yeah.
the critical terminology, and most importantly, the principles of collaborative care.
Yeah.
This isn't just about reading definitions. It's about translating that knowledge into, immediate, high-stakes, actionable clinical insight.
Our mission today is pretty laser-focused. We need to cut through all the complexity, the medical jargon, to really distill the critical distinctions and the interconnected concepts that define effective care.
Mm-hmm.
We're using two powerful but really different examples to structure this. We have multiple sclerosis, MS, as our example of chronic autoimmune dysfunction.
Right. And then spinal cord injury, SCI, as our example of acute traumatic loss of function.
And the material wisely focuses on two essential priority concepts
Yeah.
that, well, they act as the thematic bookends for this entire field.
Okay.
On one side, we have immunity, with MS serving as that primary example of a systemic failure, leading to a breakdown of CNS communication.
And on the other side,
On the other, we have mobility. Spinal cord injury represents that acute trauma that instantly and severely limits functional capacity. Understanding these two concepts, immunity and mobility, is really the key to prioritizing care for pretty much all CNS conditions.
okay, let's unpack this and start right at the foundation. Before we dive into the specific diseases, we have to grasp the basic mechanism of failure. I mean, what is the fundamental primary job of the spinal cord that these conditions jeopardize?
Well, the spinal cord is fundamentally the core relay system of the entire body. Its role is deceptively simple, moving sensory messages to the brain for processing.
And moving motor commands from the brain down to the muscles and organs, it is, like you said, the information superhighway.
Mm-hmm.
But the sources highlight that damage here is incredibly broad. It's not just limited to acute external injuries like a car accident.
No.
The spinal cord is also susceptible to inflammatory processes, autoimmune diseases like MS, or even the slow, space-occupying lesions caused by tumors, both benign and malignant. So any interruption of that relay dramatically impacts a person's life.
So let's focus immediately on multiple sclerosis, our
Yeah.
immunity exemplar. When the body attacks itself, it often attacks the most vital systems.
It does.
And the source defines MS as a chronic disease influenced by immune, genetic, and maybe infectious factors.
Yeah.
But what makes it so devastating is its target.
Yes, its target. It primarily affects the myelin and the nerve fibers in both the brain and the spinal cord, inevitably leading to progressive neurologic disability.
And the timing of this is just critical to its overall impact.
Oh, absolutely. This is a condition typically seen in young and middle-aged adults, people in their 20s, 30s, and 40s who are often in the middle of building their careers or starting families.
Right.
And the unpredictability of it all adds another layer of complexity. MS is classically characterized by these unpredictable periods of remission where symptoms might get better.
Or go away completely for a while.
Exactly. And then these periods of exacerbation, or what we call flares, where symptoms acutely get worse.
The fundamental mechanism here is what we need to zoom in on.
Mm-hmm.
Demyelination, the loss of that protective fatty sheet around the nerve fibers. For anyone trying to visualize this, I always think of an electrical cord. Myelin is the plastic insulation.
That is the perfect analogy. Myelin is responsible for that rapid electrochemical transmission of impulses between the brain, the spinal cord, and the rest of the body. If you lose that myelin, if that insulation is stripped away, the electrical impulse, it just slows down dramatically, or even worse, it short circuits and stops entirely.
And that's what causes the hallmark symptoms of MS, like the weakness, the vision problems, all of it.
All of it. And that resulting demyelination creates what the medical community calls diffuse random or patchy areas of plaque or lesions in the white matter of the central nervous system.
And those lesions, those are the definitive things you see on an MRI that confirm the diagnosis.
That's right. Initially, the body is incredibly resilient. It attempts remyelination, and for a while, symptoms may decrease during remission. But the system gets tired. Over time, as new lesions develop and that cycle of attack and repair continues, the underlying nerve axons themselves get damaged.
So it's permanent damage.
It's permanent damage, and that leads to neuronal and muscle atrophy, which drives the progressive nature of the disability.
Where exactly are these permanent lesions appearing that cause so much dysfunction? The source material is very specific about the areas most affected.
It is, and it explains the symptoms perfectly. The lesions particularly affect 5 high-traffic zones. First, the optic nerves, which is why you see early visual symptoms.
Yeah.
Second, the spinal pyramidal tracts, which are critical for voluntary motor control. Third, the spinal posterior columns, which handle things like vibration and position sense.
Right, knowing where your feet are without looking.
Exactly. Fourth, the brainstem nuclei, which control balance, eye movement, even swallowing. And finally, the ventricular region of the brain. So when we talk about irreversible neurologic disability, we are talking about permanent damage in these specific vital pathways.
Okay, here's where it gets really interesting, because MS isn't a single, uniform disease. It exists on this fascinating spectrum.
It really does.
And the prognosis and the treatment plan pivot entirely on which of these courses the patient's experiencing.
That distinction is absolutely vital for management, particularly now with all the effective disease-modifying therapies we have. We really have to distinguish the 4 major classifications.
So let's start with the precursors, the conditions that suggest MS might be coming. First up, clinically isolated syndrome, or CIS.
Right. So CIS is defined very precisely as an episode of neurologic symptoms that are consistent with MS, like acute optic neuritis or something called transverse myelitis, that lasts for at least 24 hours.
But it's not a full MS diagnosis yet.
Not necessarily. At this stage, MS may not be definitively diagnosed, especially if the MRI doesn't meet the strict criteria, but this is a siren warning. The source notes that roughly half of the patients diagnosed with CIS will go on to develop confirmed MS within 10 years.
That makes early intervention so critical, but also ethically complex. The force notes that these disease-modifying therapies are often started at the CIS stage to prevent or delay the onset of full-blown MS. You're treating someone who might get the disease.
Exactly. And that leads us to the second precursor, radiologically isolated syndrome, or RIS. And this one is fascinating. The patient has no past or current history of MS symptoms, none.
So they feel fine.
They feel completely fine. RIS is diagnosed totally incidentally. Maybe an MRI was done for a headache or a minor concussion. And yet the scan shows brain lesions that are highly similar to those you'd see in MS.
So we have CIS, which is symptomatic but not quite diagnostic, and RIS, which is diagnostic on an MRI, but completely asymptomatic.
Right, and it forces this tension on healthcare providers. Do you treat a silent disease, or do you potentially expose a healthy person to these powerful, very expensive drugs? It's a real challenge.
Now we get to the actual confirmed disease states. The most common course of MS is relapsing remitting MS, or RRMS.
Yes, RRMS affects most people diagnosed with MS initially. The course is defined by these distinct attacks, or relapses, followed by periods of partial or complete recovery, which is remission.
So during the relapse, they might lose function in an arm or their vision gets blurry.
Right, but during remission, those symptoms either decrease significantly or they resolve, and the patient returns to or near their prior baseline. The management goal here is all about reducing the frequency and severity of these relapses.
Then you have the flip side, which is often more aggressive. Primary progressive MS or PPMS.
PPMS involves a steady and gradual neurologic deterioration right from the start, and crucially, without those distinct periods of remission.
So no breaks.
No breaks. Patients show this continuous accumulation of disability without the acute attacks we see in RRMS. And the treatment approach for PPMS often differs because it's less about inflammation and more about progressive neurodegeneration.
So the takeaway here is that managing MS is managing this long, variable, and often frustrating progression, focusing primarily on this dynamic and unpredictable concept of immunity.
It's a disease defined by uncertainty. Uncertainty of when the next attack will hit, how severe the damage will be, and whether you'll ever get back to where you were.
Now let's pivot entirely. Let's shift gears from that chronic, unpredictable autoimmune attack to acute, catastrophic external injury. Our mobility exemplar, spinal cord injury.
Right.
When an injury happens, we run immediately into some very high-stakes, life-threatening terminology that requires crystal-clear distinction.
This is where terminology is not just academic. It dictates immediate life support. And the two terms that cause the most confusion are spinal shock and neurogenic shock. We have to make that distinction explicit.
Absolutely. So let's start with spinal shock.
Okay. Spinal shock is a temporary syndrome that occurs immediately following the cord injury. It's essentially the central nervous system below the injury level just going into shutdown because of the trauma.
A total shutdown.
A complete but temporary loss of all motor function, sensory function, reflexes, and autonomic function below the level of the injury. It's transient. It typically lasts less than 48 hours, but it can continue for several weeks.
So spinal shock is about a temporary global shutdown of the system due to the trauma itself. It's like a systemic electrical silence below the lesion.
Precisely. It's a physical state of flaccidity or flexia, loss of sensation. Now, neurogenic shock, that's a different beast.
Okay.
It is a specific type of circulatory shock. It's a failure of the plumbing, not the electricity. It's related to severe SCI, usually above the T6 level, where the injury interrupts the sympathetic nervous system pathways.
And what's the consequence of interrupting those pathways? What does that do to the body?
Well, the sympathetic system is what normally keeps our blood vessels constricted and our heart rate up.
Right. Fight or flight.
Exactly. When that communication is lost, the blood vessels below the injury just dilate, they become extremely wide, and the heart rate slows way down, which is called bradycardia.
So the container gets bigger, but the amount of blood stays the same.
You've got it. This massive vessel dilation leads to a widespread drop in blood pressure, hypotension, and decreased perfusion of vital body organs.
This is the crucial insight. Neurogenic shock is hypotension caused by the failure of the sympathetic nervous system.
Right.
Wide open vessels and a slow heart rate.
Yeah.
But if spinal shock can also present with hypotension, how do you tell them apart in the field?
That's the critical decision point. Spinal shock presents with flaccidity and no reflexes, and yes, maybe hypotension. But the hallmark of pure sympathetic-driven neurogenic shock is often profound bradycardia, a very low heart rate, alongside that severe hypotension.
I see.
In other forms of shock, the heart usually speeds up to compensate. Here, it can't. The immediate priority is not just fluid, but aggressive use of vasopressors and maybe atropine to manage that slow heart rate because the plumbing is wide open.
That distinction is life-saving. But there's a third, potentially catastrophic reflex that can happen in patients with high-level SCI, often much later. I'm talking about autonomic dysreflexia, or AD.
This is an absolute clinical emergency. It is a massive, sudden, uninhibited reflex sympathetic discharge that happens in response to a painful or irritating stimulus below the level of the injury.
So if the patient has a high-level SCI, say, above T6, and they have a simple, noxious stimulus like a kinked urinary catheter or even tight shoes.
A wrinkle in their bedsheet.
Wow. The whole nervous system below the injury just overreacts completely.
Completely. The stimulus sends signals up the cord, the sympathetic surge is massive, causing extreme vasoconstriction, which spikes the blood pressure dangerously high.
Okay.
But the brain tries to compensate by signaling the vagus nerve to slow the heart rate. But that signal only works above the level of the injury. So you see this severe sudden hypertension, pounding headache, blurred vision, and profuse sweating and flushing above the injury.
But below the injury.
The body below the injury is cool and pale because of that vasoconstriction.
That is a life-threatening scenario. So what's the #1 priority in managing an AD crisis?
The first, most crucial step, before you even think about aggressive medications, is to locate and remove the noxious trigger.
Right.
If you just give a potent antihypertensive without relieving the full bladder, the blood pressure might drop for a minute, but the stimulus is still there. The hypertension will just rebound and you risk a stroke. It demands an immediate systematic investigation of skin, bowel, and bladder.
That's a textbook example of critical thinking in action. Okay, before we move to chronic care, the sources highlight a few other CNS conditions and terms that the care team needs to recognize.
Right, starting with amyotrophic lateral sclerosis, or ALS. This is another progressive neurodegenerative disease famous for its devastating course. It specifically targets the motor neurons in the brain and spinal cord that control voluntary muscles.
So as the neurons die, muscle control is lost.
It is. But critically, sensation and cognitive function often remain intact, which creates an immense psychological burden.
Then there's this terrifying opportunistic infection that preys on weakened immune systems. Progressive multifocal leukoencephalopathy, PML.
PML is a viral infection of the brain caused by the JC virus. And because it's opportunistic, it often affects people with HIV/AIDS or those on powerful immunosuppressants, sometimes even certain MS drugs.
I see.
It attacks the white matter, leading to rapid, widespread demyelination. The outcome is extremely severe, typically death or severe disability very quickly.
And finally, a very common condition, usually associated with just aging and wear and tear, spinal stenosis.
Right. This is the gradual narrowing of the spinal canal itself, or the nerve root canals. It usually happens because of degenerative changes like bulging discs or thickened ligaments, and it compresses the neural structure.
And this is usually seen in people over 50.
Typically over 50, and it shows up as pain, tingling, weakness, or numbness, often getting worse with activity.
Since we are so focused on mobility, we have to master the terminology used to describe impaired movement and sensation. These terms govern everything.
Let's organize them functionally. Starting with the degree of movement loss. The root word paresis means weakness, while plegia means total paralysis.
Okay, so for the lower body, stemming from thoracic or lumbosacral injuries, paraparesis is weakness of the lower extremities.
Correct. And paraplegia is the full paralysis of the lower extremities.
And when the injury is higher up, in the cervical or upper thoracic cord, the effects are much more widespread.
Far more widespread. That results in tetraplegia, which is also often called quadriplegia.
Meaning paralysis of all four extremities.
All four. And when the term quadriparesis is used, it refers to weakness involving all four extremities. It's just a matter of degree.
Okay, next let's consider sensory perception shifts. These are so vital for assessing safety.
Absolutely. We have three key terms here. Hypoesthesia is decreased sensory perception, which can lead to unseen injuries like burns or pressure sores. Hyperesthesia is the opposite, an abnormally increased sensory perception, which can make even clothes or sheets feel painful. And hypoalgesia is a decreased sensitivity specifically to pain.
And finally, what about when the nerves leaving the spine are the source of the problem?
That is radiculopathy, simply defined as spinal nerve root involvement. This is the term you often hear when stenosis or a disc issue is causing nerve root compression, manifesting as that shooting pain or tingling that travels down an arm or leg.
We've established the acute problems, the chronic problems, and we've defined the precise language. So now if we connect all this foundational knowledge to the bigger picture, the source identifies 6 interrelated concepts that define how these CNS conditions fundamentally affect a patient's entire life.
These concepts are not just a checklist. They are the patient experience distilled into 6 core domains. They are sensory perception, cognition, sexuality, pain, immunity, and mobility.
Let's dive into mobility and cognition first. Mobility issues, especially after SCI, go way beyond just the immediate paralysis. The source highlights a concerning long-term complication of immobility, heterotopic ossification, HO.
HO is bony overgrowth. Basically, bone forms pathologically in soft tissues, most often into the muscle around major joints like the hip or knee. Think of it as bone growing where it shouldn't.
And that would just lock up the joint.
It locks the joints, causes intense localized pain, and severely compromises the success of physical rehab, which is the cornerstone of SCI recovery. So it impacts both the mobility and pain concepts at the same time.
And in MS, it's not just physical mobility that's compromised. Cognition is frequently involved. And that's often an invisible burden of the disease, isn't it?
It absolutely is. MS symptoms often profoundly affect both sensory perception and cognition, impacting memory, processing speed, executive function. The chronic nature of the disease, the fluctuating symptoms, it all contributes to this decline.
Which means patients might struggle with complex medication schedules or just transitioning between tasks.
Precisely. Let's focus on the detailed symptoms of sensory perception and coordination that the source material specifically flags as common in MS patients. Many of these relate to vision.
Right, often the first warning sign.
Exactly. Starting with vision. We see diplopia, which is double vision, making simple tasks like reading impossible. We see scotomas, which are blind spots or changes in peripheral vision, and nystagmus, that involuntary, repetitive, uncontrolled movement of the eyes.
Then we move to coordination and motor control, which are disrupted when those pyramidal tracts are involved.
We see highly specific deficits here. Intention tremor is the classic MS tremor. It only happens while the patient is performing an activity, like reaching for a glass.
Not when they're resting.
Not when they're resting. This is dramatically different from Parkinson's disease, which is a resting tremor.
And what about the inability to control the scope of a movement?
That is dysmetria. It's the inability to direct or limit movement. The patient tries to reach for something but overshoots or undershoots it.
A lack of judgment about distance.
Exactly. And the effects on coordination can impact basic communication, leading to slurred speech.
which is dysarthria.
Dysarthria, difficulty speaking due to slurred speech, often from weakness or lack of coordination of the muscles used for articulation. We also see potential issues with swallowing or dysphagia, which introduces a serious risk for aspiration.
And auditory and balance issues also fall under this umbrella.
Yes. Demyelination in the brainstem can disrupt vestibular function, leading to vertigo, severe dizziness, and tinnitus, that persistent ringing in the ears.
Now, let's turn to the concept of sexuality. It's one of the 6 interrelated concepts,
Yeah.
and the learning outcomes specifically mandate planning care to promote sexuality.
Yeah.
This is a topic that is often overlooked. Why is it called out so specifically?
This is a powerful, explicit statement prioritizing holistic, patient-centered care. It's an acknowledgement that loss of function in this area is a profound blow to a person's identity and quality of life. SCI, particularly high-level injury, involves major disruptions to the autonomic, sensory, and motor pathways that control sexual response, lubrication, and function.
So what are the clinical judgments that need to be made here? It's got to be more than just asking, are you sexually active?
No, absolutely. The clinical judgment revolves around 3 primary areas. First, understanding the type of injury, whether the patient retains reflex function from touch or only psychogenic function from mental stimuli.
I see.
Second, addressing complications like erectile dysfunction or lubrication issues, which requires evidence-based solutions like pharmacological aids or topical treatments.
And what about the psychosocial component? Fertility, body image?
That's the third crucial area. For men with SCI, fertility preservation is a major concern. For all patients, managing body image, self-esteem, and intimacy challenges requires specialized counseling and education for both the patient and their partner. A comprehensive care plan must address these intimate challenges.
This transition leads us directly into the core mission of this material: planning collaborative and evidence-based care. We've done the foundational work. Now, how is that knowledge applied in the real world?
The overarching goal, as defined by the learning outcomes, is straightforward: to provide evidence-based care that promotes all those 6 interrelated concepts through a highly coordinated, collaborative effort.
So let's break down the collaborative care objectives. The first objective is to promote mobility, sensory perception, and cognition.
This requires a highly adaptive care team. For example, promoting mobility after SCI requires constant assessment of remaining muscle strength, working with physical therapy on equipment needs, and coordinating with occupational therapy to ensure the home is safe and accessible. For MS patients, promoting cognition means using strategies like calendars and simplified instructions to manage those memory deficits.
The second and third objectives shift focus to the broader context of the patient's life. We need to decrease the psychosocial impact of living with these conditions.
This is a massive goal. Psychosocial care involves counseling for depression and anxiety, supporting body image adjustments, helping patients reestablish their roles in their families. For MS, it often means teaching coping mechanisms for the chronic uncertainty of the disease. For SCI, it means assisting the patient and family through the stages of grief.
And the care cannot end at the hospital door. The third objective is to organize care coordination and transition management for patients.
This is maybe one of the most logistically complicated objectives. These are chronic conditions managed long-term in the community. Effective transition management means ensuring the patient has the necessary medical equipment, home health services, and social support lined up before they're discharged.
And this is where critical thinking is explicitly mandated. The sources demand that providers apply deep knowledge of anatomy, physiology, and pathophysiology. You have to know not just what the injury is, but why the body is responding the way it is.
Furthermore, they emphasize the need to analyze assessment and diagnostic findings to generate solutions and prioritize nursing care. Since MS is so variable, relapsing, remitting versus primary progressive, the priorities constantly shift.
Prioritization is everything. A patient in a relapse with severe diplopia and intention tremor has immediate safety risks related to falls. That's a very different set of needs than a patient with a gradual deterioration of PPMS or an SCI patient in neurogenic shock.
Precisely.
The sources also outline specific management techniques. Let's discuss a few of these precise technical interventions.
Starting with safe patient movement, log rolling. This is a precise position change technique used to move a patient while keeping the back, head, and neck in perfect alignment. It's critical after an acute injury or surgery to prevent more cord damage.
Another essential technique for patients with compromised respiratory function, which is a major risk in high-level SCI, is cough assist.
This technique is manual assistance to overcome respiratory muscle weakness. An assistant places both hands on the patient's upper abdomen, and as the patient tries to cough, the assistant applies sudden, controlled pressure pushing inward and upward to help force the air out.
Which can prevent pneumonia.
Life-threatening pneumonia, yes. Then we have pain management, which can be incredibly complicated. The source mentions an invasive technique for chronic pain, spinal cord stimulation.
Okay.
This involves surgically implanting a device that delivers mild electrical pulses directly to the spinal cord. The goal is to interrupt or mask the pain signals traveling up to the brain. It's reserved for patients with chronic, debilitating pain that hasn't responded to other therapies.
Outside of clinical intervention, there's a massive objective focused on prevention. The sources mandate teaching adults how to decrease the risk for low back pain and, crucially, spinal cord injury.
And that links directly back to ergonomics. Prevention through education teaching, safe lifting, promoting proper body mechanics, encouraging protective gear is a primary care objective that saves lives.
Finally, we turn to the broader structural context of care. The care plan must incorporate factors that affect health equity. This brings us back to the real-world barriers the patient faces.
This is arguably the most expansive and difficult objective. It requires the collaborative team to look beyond the clinical diagnosis and address socioeconomic barriers. When managing a high-cost condition like MS, the affordability of disease-modifying therapies can determine the long-term outcome.
Right. If a patient can't afford the treatment, the best clinical knowledge in the world is useless.
Exactly. And in the case of SCI, health equity often dictates access to specialized rehab centers, accessible housing, transportation. For example, getting a high-quality, custom-fit wheelchair is essential for preventing pressure ulcers.
So a failure in health equity directly leads to a clinical complication.
It brings them right back to the acute care setting. This objective forces the care team to function as advocates. It acknowledges that access to care and resources ultimately dictate outcomes.
And we can't forget the teaching component related to MS Script. The learning outcome mandates teaching the patient and caregiver about the common drugs and management strategies.
This is absolutely essential for long-term prognosis. MS treatment relies heavily on the patient's adherence to complex, high-cost therapies that can have significant side effects. They have to understand the mechanism, the necessary monitoring, because adherence directly influences the progression of the disease.
So the care provider isn't just delivering a drug, they're partnering with the patient to understand their life, their challenges, and their ability to commit to this long-term regimen.
And that ties everything back to the psychosocial impact. If the patient is overwhelmed, depressed, or financially stressed, adherence plummets and the disease inevitably progresses faster. It's a true circle of care.
So we have successfully mapped this complex, often daunting landscape of CNS conditions. We distinguish the acute crises, spinal shock, neurogenic shock, autonomic dysreflexia from the chronic diagnoses like MS and ALS. We defined the intricate terminology that governs movement and sensation, from paraplegia and tetraplegia to diplopia and intention tremor.
And the backbone of this entire deep dive rests on those 6 interrelated concepts: immunity, mobility, sensory perception, cognition, sexuality, and pain. And the collaborative care objectives that demand we not only treat the physical ailment, but also manage the psychosocial impact and ensure health equity.
So what does this all mean for you, the learner? It emphasizes that treating CNS is treating the whole person. It demands a huge investment in critical thinking, in applying complex knowledge, and the ability to prioritize care in a dynamic way.
It also requires acknowledging the profound human toll of these conditions, especially with the chronicity and uncertainty. Given the explicit emphasis on psychosocial impact, the rise of diagnostic categories like clinically isolated syndrome.
Here is the final thought to mull over. How might the advancement of therapies for CIS, that first episode that predicts MS for half of those diagnosed, how might that specifically change the long-term emotional and financial support systems needed for patients? They now face a decade or more of living with the high risk of developing MS, rather than facing the diagnosis outright. Does the scientific ability to delay a certain diagnosis simply replace the certainty of disease with the chronic, pervasive anxiety of anticipatory illness? That's something that changes the entire mental landscape of long-term care.